Thank you for joining us today for UAMS Insiders Lunch with Leaders. I'm John Irk, Vice Chancellor for Institutional Advancement at UAMS. In advancement, we are tasked with generating support for 6 academic medicine units, a world-renowned comprehensive medical center that includes 7 medical institutes, and 8 regional campuses across the state. Our UAMS Insiders events are designed to keep our invested partners, alumni, and donors connected to our ongoing work. You are among the first to hear about new research, technology, programs, and projects that are improving the health of all Arkansans. Today, we have the pleasure of welcoming Dr. Robert Lee Archer. Dr. Archer has served UAMS in the state of Arkansas for more than 35 years. As chair of the College of Medicine's Department of Neurology for the past 6, he has done an outstanding job of recruiting talented faculty and dramatically expanding the breadth of our comprehensive and nationally recognized neurologic services. Thanks to Dr. Archer and his team, our stroke program was the state's first comprehensive stroke center certified by the Joint Commission. The Epilepsy Center is Level 4 accredited. UAMS has continued designation as a Huntington Disease Center of Excellence. UAMS has also been named as a Center for Comprehensive Multiple Sclerosis Care. Above all, Dr. Archer is known by countless grateful patients and current and former trainees for his compassionate, world-class care of patients with multiple sclerosis. During today's talk, Dr. Archer will discuss his vision for accelerating research and innovation in movement disorders and other neurological diseases, and how this transformational work will advance neurology treatment for both current and future generations of Arkansans. Please welcome Dr. Lee Archer.
Thank you, John.
Thank you, Dr. Archer.
Thank you, everyone. It's a pleasure to be here, an honor to be here. As John said, I've spent my career here, 35 years, and still going, and still enjoying it, and still appreciating. And all the accomplishments that John mentioned are not from me alone. It is truly a team effort. We've had great partnership with the College of Medicine, with the Department of Neurosurgery. We share the neuroscience service line together. And so none of this happens in a vacuum. And I'm excited to tell you about what we've been able to accomplish since I've been chair and kind of where we want to go in the future. So first, what is neurology? Well, neurology is the study of the nervous system and the muscles and the blood vessels that supply those areas. When I graduated from my residency in 1986 and joined the faculty, most neurologists could easily treat any neurological problem. But since then, there has been a real evolution in subspecialty work in neurology. And now, most neurologists do subspecialize. These include epilepsy, neuroimmunology, which would include treatment of multiple sclerosis, and more recently, patients with long COVID syndrome, movement disorders like Parkinson's disease and Tourette's syndrome, behavioral neurology, which includes Alzheimer's and other causes of dementia like Lewy body disease, neuromuscular, which would include neuropathy treatment and myopathy or diseases of the muscles, stroke, headache, neuro-oncology, which would obviously be study of and treatment of brain tumors, and neurocritical care. And neurocritical care is basically the treatment of patients in the intensive care unit that have neurosurgical problems or neurological problems. So here's a list of what John talked about. We're the first comprehensive stroke center in Arkansas and still the only one in Little Rock. The only level 4, that's the highest designation, comprehensive epilepsy center in the state. The only Huntington Disease Center of Excellence, only comprehensive MS care center in the state, only neuro-oncologist in the state, only Parkinson's Disease Center of Comprehensive Care. We have 35 active research studies totaling about $2 million in funded research. Last year we had about 100 publications and 5 books. We train 16 neurology residents. That's 4 per year for 4 years. Excuse me just a second. I promise. Usually, when you cough now, you have to announce that you're not sick. So I'll announce to I've got a bottle of water here. Thank you, John. But I'm not sick. I just had a dry throat. In movement disorders, we have 4 faculty total. All are fellowship trained. Typically, they do 2 years of a fellowship after their neurology residency. One of them also has his PhD. We have a basic science laboratory with a computerized gait mat. Gait means walking. That will record the pressure of the feet on the mat and the speed where somebody moves and the exact position of their feet so that somebody can take a medication and we can see if we've improved their ability to walk, either their speed or how coordinated they are when they walk. We have a neurosurgeon that helps with placing deep brain stimulators for Parkinson's disease. Professor Erica Peterson in neurosurgery has been a pioneer in the placement of other stimulators, such as stimulators around the spine to help with peripheral neuropathy pain. She was one of the leaders in that research that was published just a few years ago. And she told me today that she's been recruited for stimulator placement for treatment of migraine headaches in an upcoming study. So we have world-class people working with us in neurosurgery and other areas. Botox helps with spastic muscles. So my movement disorder doctors use Botox to help treat very tight muscles, sometimes called dystonic muscles, to help them relax and for somebody to be more functional. And lastly, I'll mention under this topic that we have a multidisciplinary Huntington's disease clinic because these patients have a lot of issues. They often have problems with psychosis, and as you can imagine, the social problems are often high or complex, and we have a social worker that helps in this clinic. Neurocritical care, I mentioned, was for any patient with a neurological or neurosurgical problem that needs intensive care unit care. We have 2 in our faculty that are fellowship trained. Each have done 2 years of fellowship, one in Memphis, the other in Yale, just finished his fellowship there. One is in anesthesiology and also did subspecialty training in neurocritical care. Some of the problems for neurologists are some of the neurological problems that might result in intensive care unit stay would include having intractable seizures, having weakness from a problem like myasthenia gravis, and having trouble breathing, or being in a coma because of an infection or a metabolic problem. The other intensive care units in our facility include medical, surgical, and cardiovascular. So we have 4 different intensive care unit services at UAMS. Our doctors are typically on call 24 hours a day for 7 days at a time, and then they have a week off to recuperate in between. We have 5 fellowship-trained faculty in epilepsy. They have affiliation with another neurosurgeon, Dr. Victor Police. Dr. Police is trained in epilepsy surgery where you take out a part of the brain that is causing the epilepsy. Obviously, that is delicate surgery. He's very skilled, and we're very lucky to have him and his expertise here. We monitor patients with continuous EEG monitoring to see what types of seizures they have. And at any given time, we have at least several patients in the hospital that are on continuous EEG monitoring. At Children's Hospital, there is a separate type of machine that will measure the magnetic waves instead of the electrical waves like we do with an EEG. So this magnetic encephalography machine is highly prized. There aren't a lot in the country, and we're lucky that we have that access to that type of machine as well. Stroke, when I started as chair, we just had one stroke specialist, and now we have, I said three, we have three that are fellowship trained. We have a fourth that's fellowship trained, but he specializes in general neurology right now. But the three that are fellowship trained are all MDs, and then in addition, we have a fourth person who is a PhD that helps with stroke research. They have 24/7 coverage on our inpatient stroke unit, and they cover the R-Saves telestroke network. This is run through Medicaid, and I'm told that it's the largest state-run telestroke program in the country. Let me explain what that is briefly. Any hospital in the state can be a part of this network. And if they have an emergent stroke patient in their emergency room, they can get immediate consultation with one of our stroke neurologists about how to handle that patient, whether or not to give them a clot-busting medication or send them here and let one of the neurointerventionalists take a clot out. So it's really a state-of-the-art program that Arkansas is very fortunate to have, and we're very fortunate to be a part of running that telestroke network. We received the Gold Award recently from the American Heart Association for adherence to all of their guidelines and standards for stroke care. We have a distinguished chair named after Jonathan Fitch for stroke and neurocritical care. We don't have it filled currently, but we're looking for a good candidate, and the funds are available to help with stroke and critical care research when we have a good candidate for research or a good study candidate for research. Neuro-oncology is obviously the study of and treatment of brain tumors. We're fortunate to have the only neuro-oncologist in the state. She also has training in neuroimmunology, and she sees a lot of patients with multiple sclerosis as well as patients with brain tumors. We have a collaborating neurosurgeon who has her PhD and MD, and she has an NIH-funded laboratory for studying brain tumors. We're starting the first neurofibromatosis clinic in the state that will be run by our neuro-oncologist. Neuroimmunology, besides the neuro-oncologist, I also specialize in neuroimmunology and see a lot of MS patients. And we have 2 APRNs and 2 pharmacists that are full-time with the clinic. We're very lucky that we have 2 full-time pharmacists, and they're backed up by some pharmacy technicians because these drugs are expensive and require a lot of monitoring, and so we have a lot of help taking care of these patients. Other diseases that we see in neuroimmunology include neurosarcoid and autoimmune encephalopathies. I'm lucky enough to have an endowed chair, the Major and Ruth Nodini Endowed Chair for MS and related disorders. Neuromuscular is the next category. We have 2 faculty members who are fellowship trained. One just finished her fellowship at Yale a couple of years ago. Together they run the ALS clinic, which is also multidisciplinary and the only multidisciplinary ALS clinic in the state. They are a part of a prestigious research group that's called NEALS, N-E-A-L-S. It stands for Northeast ALS Research Group, and that is considered the top research group in the country for clinical research in ALS. We have 2 endowed chairs for ALS. One is a clinical chair named after Tommy May, and the other is the Paul Dunn Endowed Chair, and it's for a basic scientist. And right now, a search committee is looking for the candidate, for the top candidate for that basic science endowed chair in ALS. We're very excited about that, and soon thereafter we hope to fill the Tommy May chair with a clinical expert in ALS. Headache. I mentioned here that headaches are the #1 problem for neurologists. It's the #1 problem we see, and it's the #1 problem that primary care doctors see. And I'll jump to the bottom there. I have a handout that includes a lot of commonly recommended things for headaches. And if you'd like that, we'll arrange for you to receive one. You can just let us know, and we'll email it to you or mail it to you. Treatments for headaches, we're lucky. The state-of-the-art with treating headaches has advanced tremendously. Botox and trigger point injections are options. I did not mention CGRP drugs. That CGRP stands for calcitonin gene-related protein. That's a new category of drug that just came out in the last few years, which has also revolutionized headache treatment. We're the only dedicated headache clinic in the state. I have 2 full-time specialists and a full-time APRN helping with headaches. Generalists. This is really our biggest need. We just have 1 general neurologist, but we probably need 4, given the volume of business that we have. Obviously, we don't want people waiting a long time to get an appointment, and so we need more. Arkansas needs more. Little Rock needs more. We just don't have enough, and nationwide, there are more jobs for neurologists than there are neurologists to take those jobs. In fact, that discrepancy is the largest among all specialties right now. Neurology is the hardest specialty to recruit to based on the number of competing jobs that a recruiter like myself is competing against. What do generalists do? Well, they often do a lot of what the subspecialists do. They'll see people that may have a transient ischemic attack, that may have headaches, but they're not that intractable. They may have some cognitive issues, but they're not, frankly, demented. They may have a neuropathy that's easily treated, and they don't need to see a specialist. So generalists can do just about anything with a large number of different subspecialty areas. Neurohospitalists. So besides neurologists taking care of intensive care unit patients, we really have the only inpatient supervised neurology service in the state. No one else has neurologists as the primary caregiver on inpatients that aren't in the intensive care unit. A lot of other hospitals have a consultant, but they don't have a neurologist that's the primary caregiver in the hospital. We do that with the help of our residents. We have 2 board-certified faculty that basically do a week on and a week off taking care of our inpatients. So they'll see people that have severe neuropathies where someone is getting so weak that they can't walk. They see the seizure monitoring patients, patients that have cognitive issues of sudden onset, such as meningitis, encephalitis, or metabolic issues. And as I said, they work a week at a time and they're off a week. We have 2 APRNs that help, and our resident physicians in training also help this service. So what are we trying to do besides expand all of these areas, particularly generalists? I was asked this recently, and I said, we really need an endowed research fund. We really need the ability to fund some what we call seed research, research that will generate NIH funding once we can accumulate some data. So this type of funding often needs about $30,000. And with $2 million in an endowed fund, we could issue several of these seed grants per year and generate a lot more NIH funding. When we did this with the Fund to Cure Stroke, our average was about 2 NIH dollars for every $1 spent in seed grants. So we know it works, and having an endowed fund is a way to perpetuate this through the years and continue to grow the amount of research that we do in the department and at UAMS. So with that, I'll walk over to John and we'll visit and answer questions.
Thank you, Dr. Archer.
Thank you, John.
It's an impressive list of accomplishments and things going on in neurology at UAMS.
Thank you.
So with that, we have some questions that were submitted. My first question would be, you did talk a lot about accomplishments, but what's the biggest challenge that you have?
Well, I think the biggest challenge is in general neurology, because it's hard to recruit to. They have so many options, and they're often lucrative options that they can go other places. I personally get emails almost every day from recruiters, saying, would I be interested in going to Florida or, somewhere that sounds exciting and relaxing to go work. So I'm competing against this, and Arkansas is kind of a secret jewel, I think. Other doctors around the country don't really appreciate that Arkansas has a very nice quality of life. Very nice people to work with, and often we have to get them here to convince them that this is a good place to live. Right. So that can be part of the challenge.
Well, we hope that if you go to Florida, it's only for a week or so.
There you go.
Yeah. So tell us what area you want to grow in neurology. I think you have 9 specialty areas. Which one needs to grow?
Well, for sure, generalists. We need to grow neuroimmunology more. We need more MS specialists. There are just so many patients in the state. Arkansas has around 3,000 patients with MS, and we need to be able to take care of all of them. And so we need 1 or 2 more MS specialists. Movement disorder, although we have 4 people now, we need more. Somewhere around 1 out of 200 people are going to get Parkinson's disease. And it's very common. And they want specialized expert care, world-class care. And if we're going to do that for all of Arkansas, we need more. We're going to need another couple.
Are there any particular neurological issues that people of Arkansas are more prone to than maybe the average? I know certain cancers were higher on the list than other states might be. Is that the case for any neurological issues?
Well, so we live in what's called the stroke belt. Right across the South, that's where strokes are much more numerous than they are in the rest of the country. Education about preventing strokes is big, and treating strokes themselves is big. There's a kind of a north-south predisposition for MS, but that really works, I guess, a little to our advantage because strokes are more common in the northern part of MS is more common in the northern part of the United States. A little less common in the southern United States, but it's least common around the equator. It's like 1 out of 100,000 around the equator. In Arkansas, it's about 1 out of 1,000. And then it's 1 out of several hundred in the northern part of the United States.
Interesting. Well, what's the most fun part about being a neurologist?
The most fun part is seeing patients. It's never boring. It's always, fun, I think, to see people. The paperwork is not much fun. And sometimes getting drugs approved, getting studies approved by third-party payers, that's a little bit difficult. But seeing patients, it never gets old. And I can tell you that my colleagues in neurology feel the same way. That's the joy, is seeing people.
That's why you're a physician, right?
Yeah.
So you talked a lot about, you have a lot of endowed chairs and things like that in the department. What role does and can philanthropy play as you grow?
Well, I mentioned that we want to start this endowed research fund. We've set a goal of $2 million for an endowed research fund. And anyone who's interested in contributing, that would be huge. To be an academic center, even though we have about $2 million in funded research right now, we really need that to grow. Mm-hmm. To be truly academic, we need to participate in a lot more research. We need a lot more researchers. There's a lot of, although neurology has made great advances since I've been practicing, there's just so much more to do.
And what are some of the specific maybe research projects that you would use those funds to?
Well, neurodegenerative research. Neurodegenerative diseases would include Alzheimer's, Parkinson's disease, amyotrophic lateral sclerosis, Lewy body dementia, multisystem atrophy. Those diseases involve a dying back in the nervous system that we don't have good reasons for. And so we need both basic science research to help tell what the problem is, and then treatment research to help ferret out the best treatments. And our Dean Susan Smythe, has made neurodegenerative diseases one of the focuses of research on this campus. And so we need more collaboration with basic scientists. So that's going to be one of our areas we need to emphasize.
Right. Now, you mentioned treatments, and one of the traditional issues in Arkansas is the people in rural areas have a hard time accessing care. So what suggestions do you have, or how can UAMS do a better job of reaching more people outside of Central Arkansas?
That's a great question. And if there's anything good that came out of COVID, it may be that we advanced our ability to do telemedicine. And so now we do a lot of phone calls and we do a lot of telemedicine where somebody, like FaceTime, we're looking at each other over a computer connection and talking. The ability to do that better has really advanced care in the more rural parts of the state. You can imagine if you're an epileptic and you can't drive, and you're in Mountain Home and you have to spend basically a day coming here and going back and then pay somebody perhaps to take you. It's a huge deal to be able to talk over telemedicine and get your visit done and not have to leave your house.
Right.
So telemedicine is a big thing that we've done, and we need to do it even better.
Right. And UAMS has kind of been at the front of telemedicine even before the pandemic. So
it was, yes. You're exactly right. We sure have.
Great. Well, what is the biggest, you mentioned your challenges to our department here, but what maybe do you see as the biggest challenge to the field of neurology in general?
Probably just the numbers. We need more neurologists. We need to train more. And I didn't mention it, but that's something else that I need to lobby for, is to expand the number of residents we train. Arkansas needs more. And studies show that residents tend to stay where they trained. They like it often and want to stay. And so we need to expand the numbers that we train.
So give us your pitch to the med student. Why should they choose neurology over some other discipline?
Well, that's a great opportunity. Thank you. I would say, what can be more fun than dealing with the central nervous system or the nervous system? It's the most complex creation in the universe. What could not be more fun than getting to help with that incredible creation? So to get to deal, and people obviously see any kind of problem in their nervous system as very threatening And so to be able to help somebody with something very threatening is, to me, just the ideal job. It almost makes me think, how could they not, like it?
Spoken like a true neurologist, of course, right? So I have one last question. It's sort of a personal question, but we have someone in Arkansas that's pretty prominent who has survived with ALS for longer than maybe anyone. What do you attribute that to? I mean, it's got to have something to do with the care that he's received here. It's got to be something to do with him.
I wish I could say that. I wish I could, but some people are just beat the odds, and we don't understand why. If I said I knew and I was responsible for it, then every ALS patient in the country would come see me and say, give me that treatment. Right. Unfortunately, it's an unknown why some people do so well. Can't tell you, but very pleased. Wish we knew that secret. And maybe that brings up, we're always looking at what's wrong. Maybe we should look at what's right with some people. Mm-hmm. You know, maybe we should study those outliers that have done so well and say, why? Why did they do so? How can we get somebody else in that category?
Right. And that brings up the need for the research funds that we've talked about.
Right.
So, well, thank you, Dr. Archer. I think that's all the questions we have from our audience. I want to thank you for being here today and for sharing your expertise and your passion for neurology. It comes through pretty clearly, I think, to the audience. Thank you all for tuning in today. Please stay tuned for an upcoming UAMS Insiders Lunch with Leaders events. We'll have more of these. You'll receive an email with more details on future presentations, and you can visit giving.uams.edu/insiders to view past presentations. We'll see you again soon. Thank you.
Thank you.